Now I'd like to introduce our next speaker, Dr. Aerang Kim. Dr. Kim completed her MD at the University of Illinois at the Chicago College of Medicine and her PhD at Johns Hopkins School of Public Health. She did her residency in pediatrics at New York University and her fellowship in pediatric hematology oncology at Johns Hopkins University. She's now an associate professor of pediatrics and director of clinical research in the Division of Oncology at Children's National Hospital in Washington, D.C. Her research has focused on the development of novel therapeutics for pediatric solid tumors, sarcomas, and NF1 associated tumors, in particular malignant peripheral nerve sheath tumors, which she will discuss here today in today's session. In addition, Dr. Kim serves as the MPNST Disease Committee Director for the Department of Defense Neurofibromatosis Clinical Trials Consortium, and has really been a driving force in the development of early phase trials for novel combination therapeutics in MPNST, which has been supported both by the National Institutes of Health and the Department of Defense. And so, Dr. Kim, thank you so much for being with us today to talk more about MPNST.
Thank you so much. Thank you so much for the introduction, Dr. Rhodes. I'm going to share my screen right now. All right. Do you guys see that okay?
Yes, we do.
Okay, wonderful. Well, again, thank you so much for the invitation to speak today, and thank you so much for the kind introduction. I am going to be discussing NF1, associated malignant peripheral nerve sheath tumors, or MPNSTs, and I have the luxury of going after two wonderful talks, and so a lot of the groundwork has been laid out. So MPNSTs are very aggressive, high-grade soft tissue sarcomas. And sarcomas are cancers that can exist really anywhere in the soft tissue, so bone, muscle, fat, and anywhere in the bodies. And sarcomas are rare tumors. There's about 15,000 soft tissue sarcoma diagnosed in the United States per year. And MPNSTs are even rarer, with being only about 4% of all soft tissue sarcomas. But what's interesting is that in about half of all MPNSTs occur in patients with neurofibromatosis type 1. And many, as discussed earlier, can arise from existing plexiform neurofibromas. I'm going to discuss that a little bit later. And we know that complete surgery is required for cure. But just as it's difficult for surgical resection in plexiform neurofibromas, often difficult in MPNSTs as well due to their size, location, infiltration, and metastases. And unfortunately, we know that survival is poor among patients who have unresectable, refractory, or metastatic disease. The median age for patients with NF1 diagnosis is about 34 years, a range kind of around 20 to 40 years, which is actually 10 years younger than patients with sporadic MPNSTs. But we also know that the association of the incidence of MPNSTs increases as one ages. And so as one ages in life, the increased relative risk also increases respectively. But MPNSTs can also span across age groups. And I've had many pediatric patients as young as 6 years old and even younger that have been reported in historically, as well as older patients as well. We don't see any gender differences in terms of incidence or survival for MPNSTs. There are risk factors that we're learning more about that can put patients with NF1 at risk for MPNSTs. And here are some of them listed here. Having existing benign plexiform neurofibromas, as we've discussed earlier, including a large tumor burden, can be a risk factor for MPNSTs. And some of those things can be things that we see, such as these distinct nodular lesions, which I'll discuss a little bit later on, as well as atypical neurofibromas that may put patients at increased risk for MPNSTs and what we consider potentially precursor lesions. Having a history of prior radiation treatment can put patients at increased risk factors. So again, we know that NF1 is a tumor predisposition syndrome and can cause other types of cancers, and having prior radiation can put patients at risk for MPNSTs. And having prior MPNST can actually be at risk for additional MPNSTs. And finally, large germline mutations involving the entire gene, or what we call microdeletions in surrounding genes, can put patients also at increased risk for MPNSTs. And I think these are things that are important to know about for patients that we treat that may be at higher risk for developing MPNSTs, because MPNSTs as well as plexiforms don't occur in all patients with NF1. But knowing what could be potential risk factors can be used in terms of thinking about screening guidelines in the future. So this is a table, and I'm just going to talk a little bit about peripheral nerve sheath tumors, but not dwell on it since it's already been discussed. But as we mentioned, MPNSTs can derive from prior plexiform neurofibromas. And we know that, as Dr. Armstrong said, plexiform neurofibromas are benign nerve sheath tumors, and they can cause a variety of functional and morbidity, including some of the same symptoms that we see in MPNSTs. But we do know that some of these, and not all, can undergo additional genetic mutations and transformations that develop into transformed MPNST or the cancer. And a lot of studies undergoing right now in these kind of in between atypical neurofibromas that develop some but not all of the genetic changes. And we believe that these may be the precursor lesions to MPNSTs. And I'm going to talk a little bit about these whole body MRIs and the foundation, where we learned about these distinct nodular lesions that are seen in patients with NF1. And the slide was provided by Dr. Wiedemann at the NCI and work done by Dr. Akshantila at the NCI. But essentially, through a study of the natural history of patients with NF1, looking at whole body images, whole body MRI images over time, they were noted to have development of what we call these distinct nodular lesions. And these are round, oval, well demarcated, usually greater than 3 centimeters, that can lie sometimes within plexiform neurofibromas, but also can be outside plexiform neurofibromas. And typically they lack the central dot sign that we see characteristic of plexiform neurofibromas on MRI. And we also note that these are a little bit more FDG avid when we look at PET scans, which is the special type of imaging that we use to look at different types of tumors. And they seem to be slightly brighter than the surrounding plexiform neurofibromas. And I'll talk a little bit more about PET scans when we talk about staging. And that we also noted that these distinct nodular lesions tend to exceed the growth rate of plexiform neurofibroma growth. And not all distinct nodular lesions are atypical neurofibromas, but many atypical neurofibromas look like distinct nodular lesions on MRI. And atypical neurofibromas are diagnosed histologically, meaning that you need to get tumor tissue in order to diagnose them. And we think that these DNLs may represent atypical neurofibromas, and obviously more have to be studied upon this. But the reason for this important is that resection of these atypical neurofibromas, even with marginal resection, meaning you take it out, but there may be some microscopic cells that are left behind, may prevent recurrence and metastases. So may actually prevent the transformation of these into MPNSTs. And the reason I bring this up is I'm talk a little bit further about potential studies that we may be able to consider in terms of a preventative or study for MPNSTs. So what are some of the presenting symptoms for patients that may have MPNSTs? So something like a rapidly enlarging mass. And sometimes, these symptoms overlap a lot with what we consider benign plexiform neurofibromas. But MPNSTs typically grow fast. And what I've learned over time is that, they have a very high rate of progression. And so if you have something that's really rapidly enlarging, that's a symptom that we need to worry about. Pain or new onset of pain or worsening pain is a very common symptom that patients may present with. And this is something that may change over time. And then also certain neurologic symptoms such as weakness or paresthesias, numbness. These are things that we should think about if these are new or ongoing symptoms. MPNST can exist anywhere in the body, and I've seen them anywhere from the head down to the feet. just because tumors of soft tissue can exist anywhere soft tissues are present. But the most common site are typically the nerve root bundles in the extremity and the pelvis, particularly the sciatic nerve. Oftentimes they're pretty large at presentation, so many of them present at greater than 5 centimeters in size. And up to 50% of patients can present with metastases at diagnosis, and the most common site of metastases are in the lung, but it can occur elsewhere as well. So really what I want to highlight is that any patient with NF1 with new worsening or persistent pain really should warrant an evaluation. And this is to be seen by your physician to evaluate what's going on because this could be concerning for a transformation. So what are the next steps if we suspect that a patient may have MPNSTs? So really the next step is further imaging and biopsy. Oftentimes there is a delay in patients with NF1 because, as described earlier, many of the symptoms overlap with many of the benign nerve sheath tumors. So enlarging mass, pain, paresthesia, neurologic symptoms, functional morbidity are things that we can see in NF1. And sometimes because many of these are arising from plexiform neurofibromas, there may be sampling errors that occur with biopsy, also causing a delay in diagnosis. So oftentimes we will recommend image guidance in order for our biopsies to occur. And some people may say, well, why do a biopsy? If we have a patient with a highly suspicious MPNST, why not just take it out? And I really believe that biopsy is important, not only for diagnosis, but also for surgical planning. There are some that may be atypical neurofibromas or these ANUPs where surgical planning will be important because not all of these tumors are surgically excisable with margins. And so it's important in terms of thinking about where this is located, how could it best be excised, and also important when planning treatment may have a role in making a lesion amenable to surgery. So what are some of the things that can be done that may make a tumor more amenable for resection? What are the imagings that we are recommending for patients with suspected MPNST or MPNST? So one is evaluation of the primary tumor. So all these tumors should have an MRI with contrast and, if possible, diffuse and weighted images. We're learning more about sequences in MRI that may be able to differentiate some benign from malignant lesions in soft tissue sarcomas. But an MRI with contrast is important, to guide surgical planning and treatment planning. And then following, we do need to evaluate for sites of metastases. As mentioned earlier, up to 50% of patients can present with metastases at diagnosis, which is really important in terms of prognostic and treatment indications. And the sites of metastases, again, the most common sites are lung, but it can occur anywhere in the body: bone, liver, nodes, abdomen, brain. So we recommend a diagnostic CT scan of the chest, abdomen, and pelvis. And at the same time, we recommend an FDG PET scan, which is more and more commonly being used for patients with soft tissue sarcomas. And I'll discuss why I think that's important for MPNST patients, not only for evaluating other sites of metastases, but also potentially working as a diagnostic tool as well. And then evaluation of the total tumor body. I put this in italics because a whole body MRI is really not considered standard of care at this time, but may be a valuable tool. I think when we have a patient with a known diagnosis of MPNST, not every patient requires a whole body MRI, but whole body MRIs may be a useful tool for patients with high risk factors in determining screening guidelines, which are not yet defined, but also post MPNST as a way of evaluating tumors and may be useful in terms of limiting the radiation exposure, as well as evaluating the entire body for screening purposes, again, post MPNST. But these are things that I think are currently under evaluation. So the other goal in terms of FDG, PET, and NF and peripheral nerve sheath tumors is that these may be a tool to actually differentiate between benign versus malignant lesions as well. And it's not completely accurate because, as you can see, there is overlap in terms of diagnoses of different types of tumors. But this SUV, so when you do a PET scan, you get an injection, and then it's an injection of a nucleotide medicine that is labeled. And so Things that are highly metabolic are typically very hot, or what we call avid on PET scan. And we usually measure that avidity by looking at what's called an SUV max. And that's how bright something can be on imaging. And we know that MPNSTs are very avid on FDG PET because they're very metabolically active. These cells are growing very rapidly. And so the SUV is very high. Whereas those for benign plexiform neurofibromas, the SUV is lower because they're not quite as metabolically active. They are more slower in terms of growth. And then other tissue wouldn't be active at all. And again, as I said, these are not completely definitive because there is overlap between MPNSTs, atypical and benign, but also a useful tool not only for disease staging in terms of looking for metastatic sites, but also for potential differentiation of the different types of tumor manifestations in NF1. So what is the treatment for MPNST? So the only known curative approach is surgical resection with wide margins. And so really that is the gold standard, and that is the only known curative approach for patients with MPNST. Unfortunately, we know that surgical resection is not always feasible. Sometimes due to the location of where these tumors are located, due to the size, due to the embedding in next to vital structures, due to being located near, embedded within plexiform neurofibromas, due to metastatic sites, surgical resection is not always feasible. And then we have a variety of other treatments, such as radiation and chemotherapy, which have been ongoing areas of debates, but I think still generally used very often. And these are typically treatments that have been derived from soft tissue sarcomas and adapted for MPNSTs. In terms of radiation therapy, we will typically use radiation therapy for tumors greater than 5 centimeters in size or after marginal excisions. So again, unlike atypical neurofibromas or DNLs where marginal excision may be accepted, for MPNSTs, we really need to have wide margins. That means that you take not only just the tumor out, but the tumor out with normal tissue. And like we mentioned, that's not always feasible. The radiation therapy can have an additive approach to that, where you can provide a local form of therapy even after marginal excision. And we try to do preoperative radiation therapy if it's feasible, because our radiation oncology colleagues will show that the total dose of radiation, if it's done preoperatively, is actually less in terms of the total amount that you receive if it's done post-excision. But again, that's not always feasible. And obviously, as mentioned, we know that patients with NF1, it's a tumor predisposition syndrome, and there are other concerns for malignant transformation. And we know that radiation therapy in itself is a risk for MPNST. So this is something that we do have to consider when we're treating patients with MPNST. But we also know we need to treat the tumor as it's now, because this is a cancer that needs to get therapy. There has been no significant proven survival benefit with radiation therapy, but again, adapted from other soft tissue sarcomas, it tends to improve the local control, which is needed for MPNSTs. And then chemotherapy. What's the role of chemotherapy, which is still somewhat of a controversy in terms of no chemotherapy or chemotherapy. And the only prospective study we have of chemotherapy and MPNST is from our SARC-006 study, which was a study of neoadjuvant. This is chemotherapy that's given before treatment with surgery or radiation with doxorubicin and ifosfamide and etoposide and ifosfamide. These are common chemotherapy drugs that are given often for soft tissue sarcomas. And what you can see here is that MPNSTs, although in some reports may say are not chemoresponsive, in SARC-006, there were many of them which were actually chemoresponsive. Not all of them responded to chemotherapy, but a significant portion did, as you can tell by this waterfall plot. And a waterfall plot, as Dr. Armstrong mentioned, is how much the tumor shrinks in each individual patient. So in this patient, we saw about 80% tumor shrinkage with neoadjuvant chemotherapy. And this waterfall plot is for patients with NF1, and this patient is for patients with sporadic. And in the past, it seems that patients with sporadic MPNST tend to have an increased response to chemotherapy, but patients with NF1 and MPNST also respond to chemotherapy. and it's not having a significant shrinkage in terms of will have stability. There has been questionable survival benefit, meaning how patients will survive in the long term in studies for chemotherapy for MPNST, but a meta-analysis, which is a compilation of statistical review of prior studies, did suggest a marginal survival benefit in patients with chemotherapy for MPNST. And chemotherapy also may be able to bridge an unresectable lesion, if you can see shrinkage, amenable to surgery, which we know is the ultimate curative approach. So I think what we really show here is that we need better therapies. You know, surgery's been around for a long time, as has chemo and radiation. There hasn't been very much change in upfront therapy for MPNST, and desperately we need new therapies. And increasingly, understanding of NF1 and MPNSTs, the availability of agents. So there's been, you know, just an explosion in the pipeline of these targeted agents, and the advancement of preclinical models to test new agents and combination approaches has really led to the development of clinical trials of targeted agents for MPNST. And I mentioned targeted agents because, you know, that's ideally what we really want to do for most of our cancers, is find a target that we know is a driver of this cancer, block that target, and hopefully lessen the acute and late side effects that we see with treatment. To date, though, there's been many trials of MPNSTs, particularly of monotherapy or single agent trials, and none have yet to demonstrate significant activity in MPNSTs. But I don't think all is lost. Many of these trials have demonstrated even in this very rare disease, when you compare in terms of all cancer therapy, we know that these trials are feasible, meaning we can enroll patients into these trials and we can get our outcomes. We also know that patients with relapse and refractory MPNST, this is a very aggressive disease with a very short time to progression, meaning that, you know, in our trials where we do not see significant activity, patients progress quickly. So we know that if we see even targets that can prolong that progression, that may actually be a signal of activity. And I think some of the things that we're seeing is that, you know, there's certain cancers that where there is a target and you treat that target and we see a response. And an example of something like that would be like a melanoma patient that has a BRAF mutation. And we know that if we target a BRAF, that patient has a response. And I think that's difficult in MPNSTs because, as you've seen in the examples, there's not particularly just one driver. We know that NF1 mutation is important, but there's multiple other genetic mutations that occur within the tumors themselves that may be driving these tumors, and that likely combinatorial approaches are going to be warranted. And then I can't stress enough that collaboration is key, and that's just something that has been an advance in NF and in MPNST. It's collaboration with our preclinical basic scientists, our translational scientists, our clinical trialists, the NF consortiums and other consortia, our industry partners, and most importantly, the NF community, our patients and families. These are what have been driving our clinical trials and driving the advances in MPNSTs. I'm going to talk a little bit about some of the trials that are open and highlight SARC-031, which is a current study that we have open right now that is coordinated through SARC, which is the Sarcoma Alliance for Research Through Collaboration. This is a DoD-funded study, and AstraZeneca is supplying the selumetinib for the study. SARC-031 is a phase 2 trial. So this is a phase 2 means that we've determined the safety and dosing in earlier studies. And now we're looking to see if we can find activity of this combination of MEK, which is the selumetinib, the MEK inhibitor selumetinib in combination with the mTOR inhibitor sirolimus for patients with unresectable or metastatic malignant peripheral nerve sheath tumors. In all these clinical trials, I do list the NCT number, which is the clinical trials number, and you can look those up in the clinicaltrials.gov website for more information. So SARC-031 is a combination of selumetinib and sirolimus. Selumetinib is given at the recommended phase 2 dose of 50 milligrams by mouth continuously, or for patients that are less than 40 kilograms at the dosing nomogram. Sirolimus is given with a loading dose on day 1, but then on a regular once daily 4 milligram dosing continuously. And patients with refractory, unresectable, or metastatic MPNST are eligible, and patients that are greater than 12 years and up are eligible. And treatment can continue until progression or unacceptable toxicity. These are the study sites that have SARC-031 open, and if there's any patients that are interested, please feel to reach out to myself or to the folks at SARC for this study. Right now, the study is open for accrual. It is currently at the second stage, and so we're hoping that we will complete accrual in the next couple of months so we can get some outcome data out. I've also listed some other currently known open studies for MPNST here, and this is all studies that have been derived from biologic rationale, which we think will benefit patients for MPNSTs. And some of these are early phase studies like phase 1 or phase 2 studies. So we have a study with pembrolizumab, which is a checkpoint inhibitor. This is a study that is sponsored through Ascentage Pharmaceuticals and open at multiple sites. There's a study of AST X727, which is for MPNST with a specific mutation, a PCR2 mutation. And this is open up at Memorial Sloan Kettering with Dr. Ping. And then plexiform 3397, which is a TKI, which is a tyrosine kinase inhibitor with sirolimus that's open at multiple sites. An intratumoral vaccine therapy open up at Minnesota. A trial of nivolumab and ipilimumab, which are also checkpoint inhibitors or immunotherapy. And this is in particular for new diagnosis MPNSTs that's open currently at Hopkins. And an upcoming soon study that's going to be run through the NF Consortium, the Department of Defense NF Consortium, which is a combinatorial study of selumetinib, the MEK inhibitor, with AZD5153, which is a bromodomain inhibitor, and Durva. I know this is a lot of alphabet soup and a lot of drugs, but I think what we're learning here is that more and more we are discovering and being able to translate some of these preclinical and translational studies into the clinics for our patients with MPNST. And then just a little mention about some future trials for consideration for these distinct nodular lesions or atypical neurofibromas, which again, as Dr. Armstrong had mentioned, is very up and aware in our community right now. And some of the things that I think we should think about for these patients who could be at increased risk for MPNSTs is the thought about prospective identification through interval imaging using whole body MRI for our high-risk patients. So again, being able to evaluate over time for patients that we think will be at high risk of developing MPNST, how can we use whole body imaging in order to identify patients, to think about preventative roles and think about preventative trials. I do want to highlight there is actually a clinical trial of abemaciclib, which is a CDK4/6 inhibitor for NF1 related atypical neurofibromas that are not amenable to surgery, that is currently open at the NCI. And then I really want to think about certain things like phase 0 trials. So phase 0 trials are thinking about the specific activity of the drug in a biologic manner. So for patients who we know have an atypical neurofibroma, who we know are already going to be undergoing resection as part of a standard of care, being able to treat with short intervals of interventions to see if we can think about tumor genomics, biomarkers, other types of imaging qualities and other types of ways we can learn about, what may be the best way to treat or prevent these MPNSTs. So finally, I know we have not made a significant amount of strides in currently changing what the standard of care for MPNST is at this time, but advances are and have been made for MPNST, both in the understanding and the biology and the ability to translate many of these findings into clinical trials. And if any community is going to be able to do it, I truly believe the NF community has a high likelihood of transforming care of patients for NF1 with or at risk for MPNST, so that someday we hope that we can cure patients with MPNSTs. And so with that, I'd like to acknowledge all the collaborators on all these studies that I have mentioned, some of the funding mechanisms, and most importantly, to the patients and families who enroll in this trial, who motivate all of us to work, and without who none of this could be feasible or possible. And here is my contact information, and please feel free to reach out with any questions or any comments. Thank you so much again.
Thank you, Dr. Kim. That was a fantastic talk. Certainly a lot of great opportunities on the horizon, and hopeful that we will see breakthroughs in this in the coming years. There is one question in the chat that I wanted to pose, which was about the use of PET scan for trying to differentiate plexiforms versus MPNST. Is there a role when that modality would be preferred versus simply just going straight to a biopsy if there are significant concerns?
Yeah, so typically I'll work concurrently with many of these with both the PET and the biopsy. So if there's a high suspicion of a malignant transformation or concern, I will get a PET in our patients, and sometimes it can guide our biopsies for these. So we'll try to biopsy the PET avid areas or the most PET avid spot because we want to be able to get the best sample possible. So again, I think there is a role for both, and the possibility of being able to differentiate between PNs and MPNSTs, but ultimately a biopsy is required, and the PET is also useful not only for differentiation, but also for staging.
Great, thank you. Just looking to see if there were any other questions. If there aren't any right now, please feel free to put them in the Q&A so that we can follow up and ask Dr. Kim in the discussion session to follow after these presentations. Thank you, Dr. Kim, again so much for being here to talk with us. We greatly appreciate it.
Thank you so much.